Hello, I am Dr. WAFAEY Badawy. I am a consultant histopathologist. I'll be talking about uterine leiomyosarcoma. Definition and general background. It is a rare, aggressive, malignant, smooth muscle tumor of uterus. It accounts for 1% to 2% of all uterine malignancies. It is the most frequent gynecologic tract sarcoma. More than 50% of all uterine sarcomas. Mean age is 60 years, perimenopausal and postmenopausal women. There is an increased incidence among black women. Clinical features include abnormal vaginal bleeding, abdominal distension, pelvic pain or pressure, constitutional symptoms, occasionally hypercalcemia and eosinophilia, rarely prior history of radiation therapy or tamoxifen treatment. It shows frequent complex karyotypic chromosomal aberrations. TP53 and VIPR2 are frequently mutated. Also, RB1 and P10. It has a poor prognosis and limited therapeutic options. Radiology images. Here in these two photos, the CT scan shows a large lobulated heterogeneous irregular mass seen replacing uterus with hypodensity necrotic areas and some calcifications within. Here, a chest and abdominal CT scan detected a nodule measuring 10 mm in diameter in both lungs. What are the main morphologic types? Leiomyosarcoma of the uterus can be divided into three main morphologic types. Conventional spindle cell leiomyosarcoma. It is by far the most frequent type. Epithelioid leiomyosarcoma, MYXOID leiomyosarcoma. Gross appearance of uterine leiomyosarcoma. Leiomyosarcomas are usually large, bulky, fleshy, poorly circumscribed multinodular masses with a mean diameter of 10 cm. The tumor is usually solitary, seen as an isolated uterine lesion, or less commonly in a background of smaller conventional leiomyomas. The tumor contour is difficult to separate from the adjacent wall, in contrast to leiomyoma, which is easily shelled out. The cut surface is soft, yellow-tan, bulging with foci of hemorrhage and necrosis. The most common uterine location is intramural, followed by submucosal, subserosal, cervical, and vaginal. The tumor is large, as I mentioned before, and has a heterogeneous cut surface, which often contains areas of yellow discoloration and friable necrotic tissue, extensive hemorrhage, irregular border with extension in two vessels can be appreciated on gross examination. That irregular infiltrative growth. Microscopic appearance of uterine conventional spindle leiomyosarcoma. Leiomyosarcoma is a cellular tumor composed of fascicles of spindle cells exhibiting smooth muscle differentiation with moderate to severe pleomorphism. Morphologic criteria for malignancy. At least we need 2 criteria for the diagnosis of leiomyosarcoma. They are significant cytologic atypia, moderate to severe, multifocal to diffuse, enlarged hyperchromatic nuclei with coarse chromatin, irregular nuclear membranes, coagulative tumor cell necrosis. The margin between viable and necrotic tissue is sharp and convoluted. That is, sharp demarcation imparting the geographic appearance. Mitotic activity. More equals or more than 10 mitoses per 10 high power field. Count in at least 50 high power fields. Choose the highest count in 10 fields. These are called hot spot areas. Disregard apoptosis, karyopexis, and equivocal figures. That is, avoid miscalculation of these as mitotic figures. I repeat again, the morphologic criteria for malignancies for leiomyosarcoma include significant cytologic atypia, coagulative tumor cell necrosis, mitotic activity. The lesion is characterized by high cellularity, border irregularity at low power magnification, and composed of intersecting fascicles. It shows severe nuclear atypia in the form of nuclear enlargement, irregular nuclear contour, prominent nucleoli, and hyperchromasia. The tumor shows typical and atypical mitosis. Typical and atypical mitotic figures. The tumor is usually heterogeneous and has areas of necrosis. Here in this photo, we see pleomorphic and mitotically active spindle cell population. Notice that most muscle characteristics, including fascicular architecture and elongated nuclei with blunted ends, cigar shape. Cytologic atypia in leiomyosarcoma is seen as large, pleomorphic, and irregularly shaped nuclei with coarse chromatin. Binucleation and multinucleation can be seen in more than 50% of cases. Vascular invasion is seen in 20%. Here we see at low magnification of a hysterectomy specimen. It shows coagulative tumor cell necrosis with abrupt transition to viable tumor. The sharp demarcation between viable and necrotic areas imparts geographic appearance. Ghost of necrotic cells can be visualized under high power magnification. The transition between viable and non-viable areas lacks significant collagen deposition and inflammation that are common in ischemic changes. Here we see in these two photos, mitotic activity in leiomyosarcoma is usually conspicuous and may include atypical mitosis. Apoptotic bodies are also frequent and should not be confused with mitosis. Avoid miscalculation of these apoptotic bodies as mitosis. Highly cellular fascicle left upper corner are infiltrating into normal uterine smooth muscle, right. Myoinvasion is a characteristic feature of leiomyosarcoma. Leiomyosarcoma with osteoclast-like giant cells. It occurs more frequently in the uterus than in any of the other places where malignant smooth muscle tumors can develop. The smooth muscle nature of the tumor cells, as confirmed immunohistochemically, distinguishes this entity from so-called malignant giant cell tumor. Here we see the neoplastic spindle cells are strongly positive for SMA, smooth muscle actin. The osteoclast-like giant cells are strongly positive for CD68. Leiomyosarcoma is positive for SMA, desmin, smooth muscle, myosin, and coldesmin. Tumor cells express coldesmin, the most specific smooth muscle marker. ER and PR are expressed in more than 90% of uterine leiomyosarcomas. CD10 is positive in up to 30% of tumors. CD10 can be diffusely positive. Differential diagnosis of uterine conventional spindle leiomyosarcoma. It includes cellular leiomyoma. Cellular leiomyoma shows conventional features including smooth non-infiltrative borders, fascicular growth, thick-walled vessels throughout, low to absent mitosis, no atypia, for example, nuclear enlargement, hyperchromasia, irregular nuclear contour, no tumor cell necrosis. At high power magnification, the nuclei has a smooth muscle phenotype with elongation and rounded tapered tips. See the inset. Here, the other differential diagnosis includes mitotically active leiomyoma. Mitotically active leiomyoma, it shows increased mitotic activity, 5 to 15 mitosis per 10 high power field. The most important difference between mitotically active leiomyoma and leiomyosarcoma is the absence of other worrisome features in the leiomyoma. that is cytologic atipia or coagulative tumor cell necrosis. Mitotically active leiomyoma behave indolently. Of note, bland tumors with mitosis exceeding 15 per 10 high power fields are currently categorized as STUMP. Leiomyoma with bizarre nuclei. Non-infiltrative smooth muscle tumors with atipia, even if marked and diffuse, should not be regarded as malignant if they lack coagulative tumor cell necrosis and the mitotic activity is less than 2 per 10 high power fields. The size of some of these tumor nuclei makes them almost visible on the naked eye. Leiomyoma with bizarre nuclei is regarded as benign. Extrauterine spread rate less than 2%. If mitotic activity is 2 to 10 per 10 high power field, this entity is categorized as STUMP. The presence of bizarre nuclei should be noticeable at low power magnification. Bizarre nuclei are typically large, irregularly shaped, and hyperchromatic, often with a smudgy appearance. Gross appearance of uterine myxoid leiomyosarcoma. Myxoid leiomyosarcoma is rare, and by definition, the myxoid matrix occupies a significant proportions, comprising at least 50% of the tumor volume. It is typically irregular and infiltrative, soft to tan to yellow, and gelatinous in consistency. Microscopic appearance of uterine myxoid leiomyosarcoma. The tumors are typically paucicellular, with cells mildly separated by an alcyanophilic myxoid stroma. The tumor is characterized by irregular, often infiltrative borders. Myxoid stroma may be a dominant feature comprising at least 50% of the tumor volume. Intensive blue staining on Alcian blue stain confirms the presence of a myxoid matrix. See the inset. That is an alcyanophilic myxoid stroma. The tumor has an infiltrative border with myometrium, not vascular invasion at the bottom. Here in this photo, we see oval spindle or stellate cells with scanty cytoplasm, which are uniformly distributed in cords or surrounded by spaces. Atipia is seen in the form of hyperchromasia and moderate polymorphism. Two mitosis can be appreciated. See the arrows. Atipia and mitosis are usually but not always present. The tumor cells have a rather non-specific appearance with scanty cytoplasm and only mild nuclear atipia in this photo. The tumor retains at least focally a fascicular arrangement, and the nuclei display the hyperchromasia and tapered end ends seen in the conventional tumors. The diagnosis of MYXOID leiomyosarcoma is warranted if the tumor has at least two of the following: infiltrative invasive edge, see the inset, the most consistent feature with adverse outcomes; moderate to severe atypia, equals or more than 2 mitosis per 10 high power fields; tumor cell necrosis. In this photo, the photo micrograph above displays scattered smooth muscle cells within a predominantly myxoid stroma. Low mitotic rate and absence of severe cytologic atypia are distinguishing features of myxoid leiomyosarcoma. High power view of a myxoid leiomyosarcoma showing pleomorphic nuclei and binucleated and multinucleated cells. Smooth muscle differentiation is becoming less evident in this photo. Differential diagnosis of myxoid leiomyosarcoma. Myxoid leiomyoma is exceedingly rare. The term myxoid leiomyoma should be reserved for lesions with myxoid stroma involving more than 50% of the tumor volume. This variant requires strict criteria for its diagnosis, which includes absence of tumor infiltration into the surrounding myometrium after extensive sampling, lack of significant atypia that is known to mild cytologic atypia, lack of cell necrosis, less than 2 mitosis per 10 high power fields, lack of atypical mitotic figures. Myxoid leiomyoma shows interdigitation between the myxoid and non-myxoid areas of the tumor. It shows spindle and stellate tumor cells widely separated by abundant weakly basophilic alcyanophilic material. If the presence of myxoid change is suspected but cannot be confirmed in a tumor with atypia and or 2 to 10 mitosis per 10 high power fields, the diagnosis of myxoid STUMP can be considered. Microscopic appearance of epithelioid leiomyosarcoma. Epithelioid leiomyosarcoma is a rare tumor with significant more than 50% of epithelioid cell morphology. The tumor is composed of polygonal to ovoid cells with eosinophilic or less often clear cytoplasm and central round hyperchromatic nucleoli. It shows sheets, nests, cords, or trabeculae, rarely pseudoglandular spaces, with moderate nuclear enlargement and atypia, a readily identifiable mitosis. Epithelioid leiomyosarcoma composed of malignant epithelioid cells and rare giant cells. The lesion is large and has an irregular contour. See the inset. Here in this photo, the tumor cells have eosinophilic cytoplasm and exhibit marked nuclear atypicality, and mitotic activity. Epithelioid leiomyosarcoma with clear cells. Keratin expression is not infrequent. Epithelioid leiomyosarcoma are rare and must be distinguished from their benign counterpart, that is epithelioid leiomyoma. Morphologic criteria for malignancy: any of the following. Tumor infiltration into the surrounding myometrium. Coagulative tumor cell necrosis. Mitotic rate equals or more than 5 mitosis per 10 high power fields. Differential diagnosis of epithelioid leiomyosarcoma. It includes epithelioid leiomyoma. Epithelioid leiomyoma is a well-circumscribed tumor and has a fleshy sectioned surface. The epithelioid leiomyomas usually clinically and grossly resemble typical leiomyomas, but some benign tumors and some epithelioid leiomyosarcomas have some gross features, including a fleshy appearance, a poorly circumscribed margin, and hemorrhage or necrosis. Epithelioid leiomyoma. Here in this photo, the tumor is composed of polygonal cells with round uniform nuclei and pale eosinophilic cytoplasm. The tumor cells have a round shape and artifactually clear cytoplasm in these two photos. There is no necrosis or mitotic activity, and the lesion is well circumscribed. Left inset. The tumor cells are strongly positive for desmin. Right inset. Epithelioid leiomyoma. By definition, epithelioid leiomyoma should have smooth non-infiltrative borders, a mitotic count of less than 5 mitosis per 10 high power fields, no significant nuclear atypia, that is mild nuclear atypia, no geographic tumor cell necrosis. Conclusion. Epithelioid and myxoid leiomyoma variants require strict adherence to diagnostic criteria, particularly lack of infiltration and low to absent mitosis, that is less than 5 mitosis per 10 high power fields for epithelioid and less than 2 mitosis per 10 high power fields for myxoid. The presence of any worrisome feature should prompt consideration for epithelioid leiomyosarcoma or myxoid leiomyosarcoma, or at least STUMP. Smooth muscle tumors of uncertain malignant potential, STUMP. Smooth muscle tumor with morphologic features exceeding diagnostic criteria for leiomyoma, including subtypes, but insufficient for a diagnosis of leiomyosarcoma, that is, indeterminate features of malignancy. STUMP is essentially a non-diagnosis, that is, a non-malignant potential, and it is fraught with frustration for clinicians and patients. Morphologically, it is heterogeneous and diagnostically challenging, so that general sampling is advised for microscopic examination. General diagnostic criteria. One of the three criteria for leiomyosarcoma should be present, such as coagulative tumor cell necrosis, cytologic atypia, either multifocal or diffuse, elevated mitotic activity more than 15 mitosis per 10 high power fields. Other useful parameters include atypical mitosis, vascular involvement, infiltrative irregular margins, microscopic features of STUMP, STUMP with coagulative necrosis as a sole finding, but lacking significant cytologic atypia or elevated mitotic activity. Here in this photo, STUMP with elevated mitotic activity at 17 mitosis. In other words, more than 15 mitosis per 10 high power field, but lacking coagulative necrosis or significant cytologic atypia. Here, STUMP with multiple foci of epithelioid morphology approaching 50% of the tumor and 5 to 10 mitosis per 10 high power fields mitosis, but lacking coagulative necrosis or significant cytologic atypia. Some STUMPs have irregular borders. FICO, surgical staging of uterine sarcoma. It includes leiomyosarcoma and endometrial stromal sarcoma. Stage 1, limited to the uterus. 1A, tumor equals or less than 5 cm in the largest dimension. 1B, tumor more than 5 cm in the largest dimension. Stage 2, extending beyond the uterus but within the pelvis. 2A, involving the adnexa. 2B, involving other pelvic tissues. Stage 3, infiltrating abdominal tissues. 3A, in one site. 3B, more than one site. 3C, metastasis to pelvic and or para-aortic lymph nodes. Stage 4, 4A, invading bladder and or rectum. 4B, distant metastasis. Prognosis and treatment. Leiomyosarcoma of the uterus is an aggressive neoplasm with an overall poor prognosis. 5-year survival rate of 15 to 65% depending on stage, which is the strongest prognosticator. Recurrence rate of approximately 70% for stages 1 and 2 and almost 100% for stages 3 and 4 within 18 months. Hematogenous spread to lung, liver is over lymphatic spread. MYXOID leiomyosarcoma appears to have worse survival compared to conventional leiomyosarcoma. Epithelioid leiomyosarcoma can have late recurrences, more than 10 years. Treatment includes hysterectomy, bilateral salpingo-oophorectomy, debulking, systemic therapy if recurrent or advanced stage disease, poor response, hormonal therapy if progressing disease. These are the references. Thank you.